Morning. Good morning, guys. This is your password. You know what to do, right? So remember when we talked about the just having the right amount of the dopamine? If you have less dopamine, what do you get? Parkinson. And if you have more dopamine, psychosis. It's because of the balance with the acetylcholine in the CNS. Okay. So when you have less of the dopamine, yes. So you have more of the acetylcholine, and you get these extrapyramidal effect, Parkinson. Makes sense, right? Acetylcholine causes, extrapyramidal effect. But then the opposite occur if you have less of the acetylcholine or more of the dopamine, then dopamine takes over and you get the hallucination, illusion, all that. Okay. In fact, like when you take an antipsychotic and if you get some extrapyramidal effect, so if it's a minor extrapyramidal effect, then you could treat it with an anticholinergic. Yes.
It started a test.
Let me get an idea of how many is not ready. Can you raise your hand if you're not at the start screen up high so I can see? 1, 2, 3, 4, 5. Okay, so maybe wait a few more minutes. So if you take an anticholinergic and it crosses the blood-brain barrier, what happens? If you take too much anticholinergic drug and it crosses the blood-brain barrier, gets into the central nervous system, what happens? You get symptoms similar to the dopamine. It's like having too much dopamine because you break the balance between the acetylcholine and dopamine, right? So you'll have more dopamine. So you could get into the confusion, delirium, hallucination, all that. It's fun, right? Believe it or not, in some cases where, some areas where there's limited access to, the bad drugs, anticholinergics are used for that purpose. Believe it or not, okay? Don't try it. Do not try it. Right, let me try now. If you're not ready, can you raise your hand? Is it just two people? Can you raise your hand up high so I can, if you're not ready? Okay, so for these two, could you please sit at the table over there and I'll bring a paper copy. Okay, is everyone ready? Is anybody not ready? Last call. All right. Go ahead. Good luck, guys. Okay, you could start working as a team now while I set the timer. I think I'm still missing one. Who's not finished yet? Okay, so let's go through the questions. Hopefully, they were not bad. Was it a bad exam? Seriously? Oh my God. Just like my kids. Always complain, always complain. All right. Okay, so smoking cigarette, which is CYP1A2 inducer. See, I didn't even expect you to memorize that. While taking clozapine, which is a substrate for that, okay, may result in extrapyramidal symptoms. We don't know the answer, but can somebody explain how this works? So we have clozapine, which is a substrate for the enzyme, and then we have cigarette smoking, which induces that enzyme. So what happens? Drug is going to be metabolized. So are we going to have more of the extrapyramidal effect or less? Less. Okay. Right. Any issues with this one? So we all know it's false. Because one of the side effects of these antipsychotics is the extrapyramidal effect. Remember, extrapyramidal is like the opposite of psychosis, which is Parkinson. So you either get, psychosis or Parkinson if you are off the balance. Yes, ma'am. Okay, so duration of action. So in this case, it would have shorter duration of action. Okay. Any issues with this one, guys? Okay. Next one. One of the most common side effects of antipsychotics is extrapyramidal syndrome, of course. Not going to even stop at that. Number 3, agranulocytosis, which is neutropenia. I'm sorry for the misspelling, is a potentially fatal side effect that is associated with the use of olanzapine. False. Which drug causes the agranulocytosis? Clozapine. Are you guys familiar with REMS, R-E-M-S? Oh, you're good. Okay. So, some drugs that are very dangerous, they need continuous monitoring. So we do not dispense the drug until we get, like some form of registration, a laboratory work to prove that the patient is being monitored and he's not getting any side effects. Can you give me another name of a drug that uses REMS? Isotretinoin, that's right, Accutane, okay? Okay, next one. First generation, which is typical, antipsychotics are more likely to cause weight gain than the second generation. What do you think? Well, no, it's false, okay? So which ones, well, of course, the second generation are more likely to cause that. I know there's a lot of information in the readings, but in the applications today, we'll see, we're gonna summarize the points of all the notes. You'll see it'll make more sense. Yes, Kendra? Okay, so it's, that anytime we talk about a side effect, it's actually not going to happen in all the people. We're talking about percentage of people, right? So we say, for example, agangliocytosis occurs in what, like 1% of the population, okay? So when we talk about the weight gain, we say that the first generation will occur, just for example, in 20% of the cases. The second generation will occur maybe in 5%, okay? So we always actually, side effects, we always look at percentages. We always look at percentage of population that will develop this side effect. So that's why we always say, when we compare between things, we say that this is more likely because the chance is higher in this than that, okay? Any other questions about that? Yes, sir. Yes, so the second generation is more likely to cause weight gain. And we will see the receptors responsible for the weight gain in the applications. We will also see the rank of the drugs, which one causes the most, okay? Good. So this is an advantage for the first generation, right? But what's the advantage for the second generation? Less extrapyramidal effect, right? I mean, think about it. You get this or get weight gain. Okay. So next one, number 5. It's like when you exercise, you lose weight when you are to have the extrapyramidal effect, right? Okay, so increase in lipophilicity of antipsychotic drugs administered by intramuscular injection causes increase the duration of action. Well, no, it's true. And you should know that this is true as a general rule. Anytime we administer something by intramuscular, if we want the drug to stay there for a long time, let's say, for a month or so, then we make it more lipophilic such that a clot would form in the muscle and then the drug is released slowly, okay? Because if it's not soluble, then it's gonna stay there for a long amount of time and then, the drug is slowly being, released. So get long duration of action. Okay? Question, yes? Huh? Say it again. Okay, yeah, that's a good question. So his concern is if there's a clot, like a depot forming in the muscle, would not that affect the body? If it's an IV, yes, that would be an issue. But with the muscle, this is like a traditional way, or like acceptable way of making the drug released slowly. Okay. So, but that's why they they rotate the site of the injection intramuscular and they choose the biggest muscle to handle that. Okay, so that's a good question. Okay. Number 6, schizophrenia is a multiple personality disorder in which a person's identity is fragmented into 2 or more distinct personality states. as silly as this question might appear, but I wanted to make sure everybody knows, because you've seen all these movies about people who have schizophrenia. They have multiple personality, but this has nothing to do with schizophrenia. Okay, so you always see these, claims that someone has a schizophrenia, and then they have multiple personalities. One time they're like a doctor, then the next day they are something else. So no, that's not schizophrenia. Okay, in fact, schizophrenia is, the best description of it is, you're not able to tell between reality and dreams. Like, imagine yourself when you're dreaming. Can you imagine you are dreaming that you're actually not dreaming? I mean, in the dream, you think this is real, right? It's only when you wake up you realize that this is not real. So the same thing happened in people with schizophrenia. They can actually see things or hear things that nobody else can see or hear, and they think it's real. They cannot differentiate between what's real and what's not real. Okay? Like, you've seen people who are like maybe standing in the street and talking to someone and like yelling and, okay? So this is an example of schizophrenia. I mean, one example, because there are positive effects, there are negative effects, negative symptoms, positive symptoms. The positive symptoms are being more energetic, talkative, all that. The negatives are the ones that, basically are depressed. They're thinking of harming themselves. They're always, want to commit suicide or something like that. John, you're okay?
Yes, my cousin is schizophrenic, and he's removed the door handle from multiple trucks and cars. He just pulled normal, and the whole handle came off.
Yeah, I know it's sad. The good thing is, if they take their medication as they're supposed to, they will live normal life.
He tries to drive to Texas. When he gets off his meds, he gets rid of his wallet. He tries to drive to Texas to see some preacher, and he doesn't have this idea. And when he's taking his meds, he's aware that this behavior is not normal.
Exactly. Yeah. It
made the news even in England when Chopper 5, instead of flying over BB King's, flew over him naked in the Mississippi River, because instead of his normal route of driving a truck,
okay,
carrying a cardboard box for when he runs out of gas, instead of carrying extra gas,
okay,
he carries a cardboard box.
Okay.
He knows he's going to run out of gas.
I know. So
he jumped in the river, and they kept trying to get him. Like, the animal control tried to get him, and the Coast Guard.
Yeah.
And people were like, and I heard about it, of course, because he's got the same last name.
Okay. Yeah. Have you guys seen the movie Beautiful Mind? That was a true representation of what schizophrenia is. Okay. Everybody seen Beautiful Mind? Or John Nash? I mean, Russell Crowe? You've seen it? You have not? This is your homework, okay? Yeah, 1 point extra for everyone who watched the movie. So, Beautiful Mind, Russell Crowe. It's a beautiful movie, actually. It actually presents the true story of somebody who's actually schizophrenic. Not only that, he was really smart. I mean, he won the Nobel Prize for discovering, like a best way. John Nash, he has an office in Princeton, I believe. No, I can't remember, Harvard or Princeton, one of these universities. Yeah, exactly. Yeah, thank you. Anyway, so next one. I know some of you suffered from this question, but it's worth, there's the saying, no pain, no gain. So anytime you have a presynaptic, guess what? What kind of receptor is this? It's an autoreceptor. Okay? Anytime we say presynaptic neuron, a receptor that is at the presynaptic is the autoreceptor. And what is the effect of these autoreceptor? They control, regulate, they inhibit the synthesis, the production of neurotransmitters. So in this case, we have an agonist to that receptor, not an antagonist. So the antagonist would do the opposite. So it's an agonist. It binds to the presynaptic neuron autoreceptor. So it inhibits the release of the dopamine, which means you will have antipsychotic effect. Inhibit the release of dopamine. Yeah, antipsychotic effect. So we all know it's true. Any issues with this one? Huh? It's hard. I know. So, yeah. Explain more. Okay. So, which one is presynaptic? Which one is postsynaptic? This is pre-synaptic. This is post-synaptic. Okay. Of course, this is the synaptic cleft. So any receptors that are located in the presynaptic, these are called the auto receptors. And when they are stimulated, they give what? Negative feedback. So they block the release of the neurotransmitters, in our case, the dopamine. Okay. So we have presynaptic agonist, which means it's going to block dopamine. And that's how less dopamine means antipsychosis. Okay. Yes, ma'am. What do you think? Dopamine, more dopamine, less dopamine, what do we get? Oh, so more dopamine means psychosis. Less dopamine is antipsychosis. Okay. Got myself confused for a second. It is confusing, I know. That's why maybe the best thing before you start the exam, just write these notes, before, so you could always refer to them. This is what I would do it, but. Okay, any issues with this one? So what happens if we block the receptor at the presynaptic? It's going to have the opposite, psychosis, okay? Or anti-Parkinson, if I want to confuse you, right? Exactly, if it's not, it's already confusing. Right. Mean professors try to confuse our students. Here we go. Okay, I think this is a giveaway question. Don't you think so? Okay, good. So we have chlorpromazine, we have dopamine. One of them is superimposed over dopamine. The other one is not. Which one is superimposed? This is the cis and trans. Of course, the cis is the one that's, it's even here, the same confirmation here is the one that superimposes on dopamine. It's not the trans. That's why the cis is the active form. Does it bind and produce an agonist effect or antagonist? It's chlorpromazine. What do you think? It should be antagonist, right? So if you are wondering why we have these extra regions, so if you superimpose this to that, you have like 2 additional rings here, right? What do you think these are doing? Hydrophobic interactions. Why did we add these additional interactions? Different induced fit. You guys forget quickly, don't you? Okay, different induced fit. Remember the induced fit signal and all that? So yeah, when you pull the receptor in a different way, so you're not gonna get the agonist, you're gonna block the receptor. That's why we added these 2 in here, okay? Just to confuse the receptor, not the students, confuse the receptors, and bind to them and think, yeah, I'm a good drug, I'm gonna bind to you, but then I'm gonna block you, okay? I'm gonna stop you from producing the signal. Okay, any questions so far? No? Last call for questions? What do you think? Okay, so the cis is more active than the trans. Which one is the cis? This one says cis, this is trans. Which one is superimposing to the dopamine more? The cis fits the dopamine better, right? So that's the clozapine, that's dopamine. This is the cis, superimpose the dopamine. This is a trans, it's outside. It does not, so this would be more active, this is not. So cis is the active form, okay? Okay, now let's start with the application. Do you need a break? Okay, 7 minutes break, 7.5 minutes, okay? Because I know like 7, why 7? Okay, 7.5 minutes break and come back. Okay, so let's start with the applications. And the first one we already talked about during the quick introduction, which is the balance between the acetylcholine and the dopamine. Okay, so do we need to visit this again? No? So we do know, more dopamine means overcome the acetylcholine, you have psychosis. Less dopamine, then acetylcholine takes over, we have extrapyramidal effect. Okay. Any questions about this exercise? So, so in the brain, there should be a balance between both acetylcholine and dopamine. So if you have more dopamine, which then it's gonna take over the acetylcholine, you're gonna have less effective acetylcholine, you get psychosis, okay? If you have less dopamine, acetylcholine takes over, and then you have extrapyramidal effects, okay? Which is Parkinson-like. Okay, so we're gonna start with the next application exercise. Three major side effects that are challenging for drug designers. So anytime we design a drug for antipsychosis, we want to get rid of these three side effects. Do you need time to look them up? Okay, let's take a few minutes. It should be quick, like maybe 2-3 minutes. Okay. Okay, so what are the side effects, major side effects for these drugs? Can you, we know the first one, the most important one is, what is it? Extrapyramidal effect, right? The Parkinson-like. Okay, what's the second one? Say it again. Antiemetic. Okay, that's one of them, but there is one that's, believe it or not, is more important. Weight gain. Yeah, weight gain is actually a major issue, guys. Okay, and we'll talk about the next exercise, which receptors are responsible for that. And can you name the third one? It's not like highlighted in the notes, but hypertension could be because of antimuscarinic, yes. Diabetes, believe it or not. So one of the side effects for these drugs is they affect the metabolism somehow that leads to diabetes type 2, okay? And then among the other side effects, as many of the antipsychotics and depressants medication is sedation, okay? So like many of these people will be feeling like, you know, out of energy, they are always sleepy and so forth. Let's see. Sedation, hypertension, antiemetic. Okay. So in fact, one of these drugs, the promethazine, is actually used as an antiemetic medication, okay? So they share the same features with the antipsychosis, but we only give the right amount of the drug to help with, you know, nausea and vomiting. You guys know that promethazine is for nausea and vomiting? Okay. Okay, any questions about this before we move to the next one? No? Okay, so the next, yes, sir.
Why is the antiemetic effect the one we want to get rid of?
You want to get rid of?
Because like the question says, try to get rid of. People say antiemetic. Why would you want to get rid of the antiemetic?
You won't actually. I'm sorry. Yeah, that's a good point. Yeah, so it's not a bad thing. It's not a bad thing to have an antiemetic effect. Thank you.
So what is the third bad?
So extrapyramidal effect, weight gain, and diabetes type 2.
Okay, just in general, the metabolic things.
Yes, metabolic rates. These are the major things because they lead to, you know, I guess, more important effects. Make sense? Okay, and the next one, we'll talk about the receptors that basically are responsible for all these effects. So once we know the receptor, then hopefully we should be able to design a drug that targets, you know, the ones that will give us the good effects and avoid the ones that give us the bad effects, okay? I know they are like spread all over the notes and many times mentioned in different ways as an agonist, antagonist. So I think it might be more efficient to just show you the receptors and what each one does. Yeah? Okay, I mean, normally I'd have you find that out, but I think it would save us time. Okay, so this is what I came up with, okay? And some of them were not really, like some of them I could not find what's the effect. But anyway, so on the D2 receptor, remember, notice that I separated them into autoreceptors and postsynaptic. Okay, so the auto receptors are the ones are located where? Pre or postsynaptic? Pre. So do you want to design an agonist on these D2 autoreceptors or an antagonist? An agonist, right? Because we're gonna give a negative feedback. So agonists on these receptors will prevent synthesis of dopamine, which means you reduce the psychosis. On the postsynaptic D2, we want to design an antagonist, of course, and we get the antipsychosis. Which one is responsible for the extrapyramidal effects? Binding to the autoreceptor or binding to the postsynaptic? Well, based on this, it says postsynaptic. I'm trying to think if the autoreceptor would increase dopamine, so it should also cause extrapyramidal effect, right? Let's see. But in the case of the postsynaptic, we're more specific on the D2. Here, it releases dopamine and affects all the receptors, not just the D2. But anyways, remember the pathways we had for the dopamine? You know, these weird names of the something that Kendra named them for us. So some of these pathways in the brain, they affect the emotions and, right? Another pathway affects the movements. Guess what? When we design a drug, you know, unfortunately, we're not able to target one area versus the other. So our goal is to affect the area that's responsible for the, you know, psychosis, all these emotional and, you know, hallucinations. But the drug gets to the other pathway, and that's when you get the extrapyramidal syndrome. Okay? So the reason we get these extrapyramidal syndrome is because although we are, you know, we should control the dopamine release in one region of the brain, but it affects another region and leads to the extrapyramidal syndrome. Okay? Makes sense, guys? And I will post this, you know, in case I know you're busy taking notes, but the H1 antagonist plus the 5-HT2C antagonist are the ones responsible for the weight gain. Has anybody heard of the cyproheptadine? No? Cyproheptadine solution? It's a prescription drug. It's an antihistamine. It's actually used to help people gain weight, okay? I've seen that actually given in solution for children who are not, you know, their appetite is not helping them. So they actually use the cyproheptadine to help them, you know, increase their appetite so they could actually, you know, eat more, okay? So by targeting these drugs, they target the H1 antagonist. In fact, that's what promethazine is, the anti-nausea, anti-vomiting promethazine. It's an H1 antagonist. So they target the H1 receptor, antagonize it in the brain, and they increase weight, they cause weight gain. And these receptors, the 5-HT2C, when they antagonize as well, the, you know, serotonin 2C receptor also causes weight gain, okay? And then finally, we have the 5-HT2A antagonizing this receptor will give you antipsychosis, which is the new generations of the drug, the second generation. They have less effect on the D2, okay? And they have more effect on the serotonin, which is why they have less of the EPS effect. But they causes more weight gain. Let me say this again. So the newer generations, they are less potent to the D2, and they are more potent to the serotonin receptors. Because of that, we still get the antipsychosis, and we get less of the APS, but we get more of the weight gain because these are serotonin receptors. So guys, anytime we say 5-hydroxytryptophan, 5-HT is a short for serotonin. I'm sorry, I should have said that. So serotonin receptors, 5-hydroxytryptophan, 5-HT. Yes, so, but you know, some drugs target, our goal is to selectively antagonize this one, but because, you know, we're not good enough in selecting drugs that target only one receptor, they accidentally target this one, so we get weight gain. So with the second generation, with the atypical antipsychotics, we target more of these receptors, less of the D2. Okay, so we get antipsychosis with weight gain and less of the EPS. And finally, we have the muscarinic receptors. You get all these anti-muscarinic, and then we also have some effects on the alpha-1, alpha-2, which I don't know what that affects. So. Yes. Say it again. Oh, so I was saying, after the serotonin, we have the muscarinic receptors, anti-muscarinic effect, and then there is some effect on the alpha receptors too, but it was not explained exactly whether it's an agonist or antagonist and what effect that could be. But we're looking at these major things. Okay. So hopefully now when you see that, then when you read the notes and you see that, one drug targets these receptors, but not that, and they have more weight gain, but not, APS, then we know why is it the case. Okay. Okay, see lots of confused faces. I will not be able to sleep at night. Right, questions? Maybe I should put the answers comparison between 1 and 2 in the next exercise so you could actually. Okay, so this actually is a comparison. Okay, so in the next exercise, there's a comparison between the first generation and second generation. Like we said, the first generation has more affinity to D2 receptor, which means more APS, and it has more extrapyramidal effect, but it also has more effect on the positive symptoms. Remember, psychosis has positive and negative symptoms. And then with the second generation, has less affinity on D2, but more on the 5-hydroxytryptophan and other receptors. And that's why you have less of the EPS, but then you have more weight gain, okay? And then it was found to have more effect on the negative symptoms. And then this one here ranks the effect on weight gain. Clozapine, olanzapine has higher effect than quetiapine, risperidone, and all that. So I think this will make sense with the one before it here, knowing that the second generation targets these, okay? The first generation targets more into that. Okay, now questions. So you're busy taking notes. No, of course I will. Are you kidding me? How should I trick you then if I don't post them? Yes, sure. Yes, so remember psychosis has both positive and negative symptoms, okay? So the positive symptoms are, think about them of being like, energetic, you want to talk and like, yell and do all these things. Right, so the first generation affects the positive symptoms more. The second generation affects the negative symptoms. Negative symptoms mean like you're depressed, you commit suicide, you think about negative thoughts about yourself and people around you, and mostly you want to harm yourself, not others, actually, believe it or not. Okay. So then the first generation was found to be more useful in someone who has positive symptoms. If someone has more of the negative symptoms, then the second generation was found to be more useful. Yes, Millie. Oh, type 2 diabetes? I'm not sure, to be honest. I know it's one major concern because, if you end up having diabetes, it's like, one of the worst diseases you can ever have. It could progress to many complications. So I'm not sure which one has more effect on the diabetes. If you find out, let me know. Actually, it make more sense. Yeah, actually, I did. Maybe I forgot already. Okay, actually it makes sense because actually, believe it or not, one way to treat diabetes is losing weight, right? So if you lose more than 50 pounds, don't quote me, but if you lose more weight, then you actually could like come out of diabetes. You could actually treat diabetes, okay? So by gaining weight, then you actually end up having more diabetes. So yeah, let's say, here, the second generation will have more weight gain, and then would make sense to say that, more diabetes. But again, sometimes we rationalize, which is beautiful, but then we get shocked by these experimental, clinical studies. So, okay, thank you. You had a question, Vivian. Okay. Yes. Yes. Oh, she was, yeah. Questions? Last call for questions. Okay, so can someone summarize this? Why do we care about the receptors they bind to, and how is the first generation different from the second generation? Oh, so I need someone to summarize exercise number 3 and 4, and why, do we care about which receptors they bind to, and why do we see different effects and side effects from the first generation and the second generation based on how they interact with these receptors? You wanna do it? Good. So we're giving Adishola a break, huh?
So from my understanding, when you have the first generation, which is the typical, they have a higher affinity of binding to the D2 receptor, which causes the extrapyramidal side effects. And then the second generation, which are the atypical drugs, they have less affinity to the D2 receptors, but more affinity to the serotonin receptors, the histamine receptors, I'm sorry, such and such. And they don't cause the extrapyramidal side effects, but they cause the weight gain because of the higher affinity to the serotonin and the histamine receptors. What was the other part? That was it? Okay.
Excellent. Thank you so much. Now, why I couldn't do that? She said it's much simpler than mine. Anyway. Okay. Questions? Okay, well, let's move to the next exercise then. Exercise number 5. Hide my notes. Exercise number 5, identify the advantages of the keto function group. Okay, that's an easy one. Okay. So exercise number 6, explain the reason for being able, we will do 5, I'm just reading the questions. Explain the reason for not being able to classify them, and then identify the basis of antipsychotic versus. Okay, so actually number 7 is related to 3 and 4. So what are the bases for selecting one versus the other? Which one do we go with as, as first generation or second generation? It depends, really. It depends on, first, does the patient has more of the positive symptoms or negative symptoms? Okay, it depends. Would the patient has, more concern with the extrapyramidal effect? Is the patient more concerned with the weight gain? Okay, so these are the factors we look at when we decide which generation to go with. Okay, so since this is related to the previous exercises, Okay, so let's go ahead and do 5, 6 together. So you guys take your time and try to find the answers for number 5 and 6. It should be easy, so we could finish that. So maybe in like at 10:35, we will talk about these two exercises. In the meantime, if you have any questions, please raise your hand about anything before I can help you with it. Okay, so I assume you get the answer. You were able to find the answer. So what's the purpose? Why did we add the keto function group to the haloperidol? Or what's the advantage of adding the keto function group? Longer duration of action. Okay. It also led to the discovery of another drug besides haloperidol that is used to treat Tourette syndrome. You guys know what Tourette syndrome is? You do? You watched the video?
But I gave my fake patient.
Oh, really? Okay, awesome. Good. Okay, so, you know, so this is like one of these trial and error. You know, you try something and then you find a new drug and you find that it works for a certain disease and you probably cannot explain the mechanism of action, but, you know, that's one advantage. I think, you know, that's a good, you know, example to share how sometimes by trial and error you could find a drug to treat something. Okay, and then in the next one, why in some, you know, are we not able sometimes for some drugs to say that this is dopamine agonist, antagonist, or inverse? For some of these drugs, they actually bind to different dopamine receptors, or sometimes to the same dopamine receptor, but as an agonist or as an antagonist or as an inverse agonist, simply because of the multi-functionality of that receptor. These receptors, they look the same from outside, but from inside, these are GPR receptors, right? GCPR receptors. So when they are stimulated, they conformational change, produce, you know, next message to the protein, G protein, and then G protein moves the message to the next and so forth. So anyway, from the outside, they're the same, but the inside, they're different, okay? So for the same receptor, you might see the drug binds to it, to a certain region in the brain, and then produces some effects that are like an agonist, okay? For some other receptors, the same receptor from outside is the same, the drug binds to it, it produces a negative effect. Think of the D2 receptor, which autoreceptor, and at the same time, it's located in the postsynaptic, okay? So, which is why, you know, we are not, you know, finding the best drugs for, you know, antipsychosis as well as anti-Parkinson. So one of the most challenging receptors to understand are the dopamine receptors, okay? Because of their multifunctionality feature, okay? Just wanted to throw this exercise in to give you an idea how challenging is that. Aripiprazole actually was functionally selective, which means that they actually, you know, bind to certain receptor and produce the effect that is wanted, and they avoid other receptors. You know, they avoid the receptors that produce the unwanted effects. It's not. See, I want you to catch the term. You know, functionally selective versus, you know, receptor selective. So aripiprazole, it selects the receptor and produces the preferred effect. Okay. And we don't know how this happened. It just, you know, one of these features. Okay. Questions about these two exercises, 5 and 6? Functional selectivity, okay. So you know how we have the GPCR receptors? Part of the receptor is outside the membrane, another part is inside, okay. So the same receptor in different places in the brain will have the same structure from outside, okay, but from inside, it gives a different effect. It could be positive or negative effect, like stimulation or inhibition, okay? So this makes it difficult for us to design an agonist to the receptor because from outside, they'll all look the same, okay? So they have different function. So the receptor is stimulated, but they have a different function. Yes.
So you're saying that basically we don't understand, and I may be just repeating what you said, but I'm trying to confirm. The receptor, we don't know why the drug binds the right one, but receptor site's identical, but for some reason, it only binds the ones that cause this. And it's just that cause a certain function, and we don't know.
So it has just we don't know how it happens. We don't understand, which conformation produces the change that leads to the stimulation, which conformation choose the inhibition. Besides, on top of that, the receptor itself will give a different signal when stimulated. So the same receptor, when it's stimulated, gives a signal that could be a positive, stimulation or inhibition. Okay, so depending on its location in the brain and depending on the pathway, so which is the reason why it's really complicated. And we normally go by the pharmacology or by the clinical studies to decide to see the effect of these drugs. Okay, that's why they are called pharmacocentric, which means these drugs are, I guess, studied based on their effect, not based on their structure, how they bind to the receptor. Okay. In terms of selectivity, so aripiprazole is a second generation, and it was found to be functionally selective, which means it can actually differentiate between one receptor and another. It can produce the function that is needed on the dopamine receptors. Okay. I think that's the only example in the notes, aripiprazole. Questions? Any questions about any of these exercises or the rats or the material on today? Anything? Number 3, okay. Uh-huh. Which receptor? Oh, the post and pre? No, not the first one, the second one. The H1? On the second one, oh, postsynaptic? Okay. So this is actually the the common theme is when we target D2 receptors, we block them because we have too much dopamine, and that's what psychosis is caused by, too much dopamine. So we block D2 receptors. Normally, when we talk about blocking D2 receptors, we block the postsynaptic. Now, this one here is an exception where you have D2 receptor and the presynaptic, which are known as autoreceptors. Now, these ones, if you design an agonist for them, then you stop the synthesis of dopamine. The second one, it's in the postsynaptic. These are dopamine receptors that we need to block, okay, to stop the psychosis. So the D2, I thought D2 was supposed to inhibit like dopamine. That's not the function of D2. Okay. Okay. Right. So D2 family and D1 family. This is a very good question. So guys, remember D1 family and D2 family from last lecture? Okay. So in this case, the studies shown that D2 was the most useful one in treating psychosis. You might think, why don't we try D1 family? Why is it that the D2 family as the inhibitory? We really don't have answers for these. It's just based by experiment. Just like when we said in the previous anti-Parkinson, when we expected that we should be targeting the D1 family instead of D2, but then studies have shown that designing D2 antagonists, well, in that case, it was agonist. Designing a D2 agonist was still giving anti-Parkinson effect. So notice that in both cases with the Parkinson and with the schizophrenia, drugs works on D2 were found to be useful. Okay.
So if the keeping antagonist, the anti stops the psychosis, that's like anti, right?
Yes.
EPS is the extra pyramidal.
Yes. So EPS is the extrapyramidal symptom, which is because of this balance here. Okay. So there should be a balance between dopamine and acetylcholine. So when you block, when you have less of the dopamine, acetylcholine takes over, and then you have the extrapyramidal effect. Okay. Sure. Yeah, we'll do that. Okay. Any other questions? Yes, Daniel. Yeah. Okay. So now, since we know the receptors, or at least we think we know enough, so what would what would be an ideal antipsychotic medication? No side effect. Yeah. How do you do that? So you probably wanna target the D2, but not cause the EPS, which is difficult, right? So maybe you wanna target the serotonin, but if you do, you probably wanna avoid the 2C. So maybe if I wanna design something, I would target the 5H2A and get the antipsychosis, but not avoid the 5H2C such that I can avoid the weight gain. This way I would treat antipsychosis and I'm not targeting D2, so I would have no EPS, and then I would avoid this receptor to avoid the weight gain, and then hopefully avoid any antimuscarinic or H1 antagonist. So maybe just target the 5-HT2C. I'm sorry, the 5-HT2A. Okay, so if I can design a drug, then I would experiment that and then see what would be the outcome. Hopefully, I would have no EPS, no weight gain, or yes, ma'am. Are you asking me, do I think combining, would that be a better? So this is what the second generation is doing. So with the second generation, they target D2, but they are less potent to D2. So you have less of the EPS, okay? And they have more on the serotonin. So they have still antipsychotic, but this time they are affecting the negative symptoms, okay? And the side effect of targeting the serotonin receptors is the weight gain. So do you really need a balance of both? I think if you just want to target this receptor, then you can treat antipsychosis. But I just remember now there is also the positive symptoms. So with the positive symptoms, you need something to inhibit the D2, okay? Because serotonin are more like on the negative symptoms, okay? So it's really a hard, unless the patient, see, people who have schizophrenia, they can have both symptoms, positive and negative. They can have more of the positive, they can have more of the negative. So you want to decide what is the best option for them with the first generation or second generation. Yes, no.
Would you also take body habits into consideration?
Which one?
Body habits?
I'm sorry, body.
Body habits, like
Uh-huh.
if they're already obese?
Oh, yes, of course. Yeah, exactly. So in your selection, you will consider if they're already, have overweight. If they're already overweight, then of course you want to select which one would be the ideal medication. Exactly, negative. Exactly. Yeah, it's a challenge. I know. Yeah, I mean, yeah. So we don't have the ideal medication. So that's a good question. She's saying, What if somebody already has a diabetes and they're overweight, but they have negative symptoms, right? I mean, we're not gonna ignore the positive I mean, we're not gonna give them first generation. We're still gonna give them second generation, but we have no choice, right? I mean, that's the best you can do. I have to say that, you know, these drugs, they, you know, I classify them as first and second generation, just for simplicity. But if you look at this rank here, for example, okay, you can see that some of them has more effect on the weight gain than others. So you can still select among these, okay? So the affinity of these drugs to the various receptors will give you different variations of side effects, different variations of effects on the positive and negative symptoms. So once, if you really wanna, you know, like be more detailed, then you could make a table maybe and then compare all of them and put the ones that has more effect on the weight gain, ones that have more effect on the positive symptoms, negative symptoms, and so forth. And then based on the patient case, you would want to select the best option, okay? So, no, I mean, not really. I mean, I would look at the just the general idea of how first generation has and what second generation has, okay? Okay. Yeah, but that's a good question. So how would you choose? It's based on the symptoms the patient has and the side effects each drug produce. And then, like I said, because of the different binding affinity and effect of these drugs on different receptors, then you could actually pick from them and find the one that best fits that patient, okay? I've known someone who's actually been taken second generation, was controlling their APS very well. I mean, sorry, the psychosis very well, but then they were like complaining about their weight gain, right? So they switched to a different medication. It is still a second generation, but now they lost control of the psychosis, and you know, they no longer get the weight gain, but they're still getting the psychosis effect, which is horrible. So now they went back to the first medication, you know, having to deal with the weight gain but not having the psychosis. So within the same class, you have variations. Which one can cause more weight gain? Which one can cause more psychosis? Which one can cause EPS? Okay.
So like based on that, this one comes first, the person gaining weight and is still having the psychosis, or the person, the person gaining weight and
Right.
having less of the psychosis dealt with than the person losing weight and the psychosis not taken care of. So you have to like.
What do you think?
I think the first one is better.
Which was the first one?
You don't care about the weight.
Yes.
Like ending the psychosis because
Yeah.
that's what you really want.
And you might be able, hopefully, to like find other ways to control. Yes, like maybe exercise or diet or something. Yeah, yeah. It's easy to say, but then, you know, each patient is different. They want the best medication, so they need something to not cause them weight gain and treat their psychosis. And if you can find that, that would be best. Okay, Kendra. Right. Right. So the general classification for, you know, first generation is that the second generation causes the weight gain, but some of them causes more weight gain than the other. So if you can look at, for example, aripiprazole, which has the least incidence of causing weight gain. Okay. Oh, phentermine is a synapse stimulant. It will actually block the appetite. That's right. I'm not sure how this will interact with the antipsychosis. So we're talking about CNS stimulant there. So yeah, I mean, that's a good point, of course. Yeah, so like maybe I would select between haloperidol, aripiprazole, and see if this would treat the psychosis they have. If they do, then be ideal. Then I don't have to worry about. Okay. Well, we finished early. So let's have a break and come back. What do you want to do? You want to look at the cat exercise? Okay, so let's take 7.5 minutes break and come back because we have a lot of questions to go through, okay? Okay. If you do not want to stay for the review, that's fine. Okay, guys. If you, for some reason, you do not want to stay for the review, that is fine. Just make sure you give me the sign-on sheet before you leave. Okay, so we have like 35 questions. So I'm gonna skip the ones, or actually, go through the ones that are easy quickly. So this one, we had question number 1. We have something similar to that in the practice exercises. Okay. So do you have any issues about this one? Question number 1. So it was what? So here we're talking about binding affinity. You're going to rank them by binding affinity, right? So what kind of interactions do we have here? Ionic, hydrogen, van der Waals. Ionic, hydrogen, van der Waals, another van der Waals. So definitely this is more than that, more stronger than that. Ionic, hydrogen, van der Waals, another hydrogen. So these two for sure more has higher affinity than that. Now between these two, which one has more affinity? C, because it has more, because hydrogen is stronger than van der Waals. So it'd be CBA, okay? All right, and the next one, drugs that have more single bonds are less likely to bind to unintended receptors and produce side effects. So more single bonds means what? In terms of isomers, and more single bonds means more conformations, right? So what's their ability to bind to other receptors, higher or less? So it should be more likely. So this is wrong. Okay, it should be more likely to bind to the unintended receptors and produce side effects. Okay. B, modifying a lead compound to satisfy the required pharmacophore is an example of optimizing pharmacodynamic properties. What's the difference between pharmacodynamic and pharmacokinetic? So dynamic, we're talking about drug binding to the receptor, right? Pharmacokinetic means the drug is going to the receptors, like leaving from the mouth, stomach, all the way in the blood, and then reaching the receptor, okay? So here we're talking about pharmacodynamic. So modifying the lead compound to satisfy the required pharmacophore, okay, how the drug binds to the receptor, is optimizing pharmacodynamic. What do you think? True? Okay. And then if a molecule is not superimposable to its mirror image, then it would be achiral. If it's not superimposable, it would be actually chiral, right? Okay. And then using a racemic mixture of a drug makes it more selective. I mean, if you stop here, that's wrong already, right? Then using more than one. So when you have a mixture, you have, the cis trans, then you're actually less selective because you could bind to more than receptors than if you only pick one of them. Okay. So any issues with this one? Question number 1 or 2? Any issues? Okay. Number 3. Okay, so it says drug A has the highest affinity. Drug D is most potent. Drug B has the strongest interactions. Well, all of them actually talks about affinity because affinity, potency, and strong interactions, they're all related to each other, right? If you have strong interactions, then you have the highest affinity. If you have the highest affinity, then you are the most potent. So which one of these is most potent, has the strongest interactions, and has the highest affinity? Which one? B. We all know it's B, okay? Because look, this is the dose, this is the response. So this one here will give you the effect before anything else, B, okay? So in terms of potency and interactions, affinity, B is the most among all of them. Now, what's the problem with B? Efficacy, okay? So we are not talking about efficacy here. B has the lowest efficacy, Okay. Any questions about this? The answer is C. Yes, I'm sorry. Okay, next one. Okay, in order to take advantage of the blood-brain barrier, okay, we have two kinds of drugs. One of them is lipophilic, the other one is hydrophilic, okay? And then we have the fact that one of them would cross the blood-brain barrier and the other one will not. So I think the trick is, if the drug crosses the blood-brain barrier, does that mean that it will only work in the blood-brain, in the brain, or can it also work in the peripheral? It's going to work on both the peripheral and the brain, right? If the drug does not cross the blood-brain barrier, it means it's going to bind in the peripheral, but it's not going to reach the brain, okay? So this is the advantage we want to keep in mind. So let's go through one by the other. I mean, these are the points we want to keep in mind. So drugs can be made more lipophilic such that they can act in the brain, not in the peripheral. So if they are more lipophilic, yes, they will bind across the blood-brain barrier and work in the brain, but does that mean they are not going to work in the peripheral? That's wrong, okay? They will still bind to the peripheral and cause effects on the peripheral, okay? Think of the antihistamine, the first generation antihistamine, Benadryl, right? It binds in the peripheral and relieve the itchiness and, you know, dry, I mean, the, you know, eyes, tears and all that. But it also crosses the blood-brain barrier, goes into the brain and causes sedation, which is why, you know, Benadryl is also marketed as sleeping aid medication, Unisom. Okay. The next one, drugs can be made more hydrophilic such that they can act in the brain. No, we already know that hydrophilic will not even reach the brain. Drugs can be made more hydrophilic such that they can act peripherally, but not in the brain, right? So that's true, because when I design a drug and makes it polar, then I can be sure that it's not gonna reach the brain. It will only reach the peripheral. An example of this would be the second generation antihistamine, okay? Now the second generations are more hydrophilic. So guess what? They bind in the peripheral, they release the, you know, itchiness and all these horrible effects of allergy, yet they do not cross the blood-brain barrier, so they do not cause the sedation, okay? Unless you overdose, but that's another story, okay? So C is the correct answer. D, drugs can be made more lipophilic such that they can act peripherally but not in the brain. No, of course, if they are more lipophilic, they will reach the brain. Okay, any issues with this one? You're so quiet. Number 5, we have seen many examples on number 5. So we have a substrate and we have an inducer. So this induces the metabolism of that. So guess what? You're gonna have less of this sertraline, okay? So you will have underdose of sertraline. Everybody agrees? Okay. Number 6. What statement is most correct? Drugs that are bound to plasma protein, such as albumin, have larger elimination T half-life. What do you think? They bind to the plasma protein, so they will have longer duration of action or short? Long, which means that the T half-life would be also larger. Okay, so that is, so A is correct. And then lipophilic drugs have smaller apparent volume distribution compared to hydrophilic. Wrong, because, for example, lipophilic will cross the blood-brain barrier and they will occupy more volume. Okay, so this is wrong. And then lipophilic drugs have shorter duration of action compared to hydrophilic. What do you think? It's wrong, because just like with the plasma protein, when a drug binds to plasma protein or lipophilic, the fatty tissues, it stays there for longer amount of time, okay? And then the unionized form of a drug is excreted easier than the ionized? No. In fact, that's why we use metabolism to make the drug more polar, okay? Such that it can be easily excreted. Number 7. Any questions about the one, number 6, guys? Okay, number 7, drugs that are bound to plasma protein have higher volume of distribution and should be administered at higher dosages. So we all know it is true, but why? So they are bound to plasma protein. How can a drug that binds to plasma protein have larger volume of distribution? If you're surprised, means that there's something is missing. Yes, Kendra. Okay, so whenever we talk about volume distribution for a drug, to differentiate it from the actual volume of the fluids in our body, we use the term apparent. Okay, because the volume or the amount of water in our body is fixed. But for one drug X, MI has a different volume than drug Y, because drug X will distribute in a smaller region while drug Y will distribute in a larger volume. So we use the term apparent. Okay. So when a drug binds to the plasma protein, then would you need more of the drug? Yes, because when it's bind to the plasma protein, then it's not interacting with the receptor. Only the free amount of the drug that is soluble in the plasma, in the the plasma serum, that's the only one that's actually interacting with the receptor. So when a drug binds to the plasma protein, it's going to be taken away from the plasma, okay? So you'll have to give more of the drug, which is, in other terms, it's like you're trying to fill more volume to get to the right concentration. So the volume of distribution will appear to be more than if a drug does not bind to a plasma protein. Does it make sense? Okay, yes. Sure. Okay, so this is one thing, plasma protein. Now, on the other hand, or I should say, in case you have another drug that also binds to the plasma protein, then we're talking about interaction here. We're talking about a drug interacts with another drug. They compete for the plasma protein. So one of them, depending on which one has a stronger affinity and depending on which one has more concentration or higher amount, so the one that has more amount or has stronger binding affinity will displace the other one. So now the one that's been displaced will be in the available to bind to the receptors. It can cause side effects. Okay. Okay, so if you have two drugs that bind to the plasma protein, they compete for the plasma protein, okay? So the one that has a stronger affinity or stronger binding interactions will displace the other one. And so the other one will be actually be available in the plasma and bind to the receptors and produce side effects. This is one example of drug-drug interactions, okay? There are many examples of drug interactions like we saw, you know, the affecting the metabolic enzymes is one way, but another way is, you know, by competing to the plasma protein. Yes.
What's my confusion is, I thought if you were bound to plasma protein, they concentrated them in a certain area, but that wouldn't equal in my head a higher volume
Okay.
overall.
Okay. So I think the best way to explain this is let's say that this is a vein. Okay, this is another vein. Okay, and these are plasma proteins. Okay. And if we give a drug X that binds, we have drug Y does not. To plasma. Okay, and let's say that we give the same amount. Let's say that we give, 1 milligram. Okay, so this one binds to the plasma protein. You'll see some of the drugs here. Okay, and some of them here. This one would not. So maybe one here and the rest will be here. Okay, so now you take a sample of that drug. Let's say you want to calculate the volume distribution, right? So the volume distribution would be equal. Remember, concentration equal dose over volume. So the volume is equal dose over concentration. So that would be the dose over concentration. Okay. So now the dose is fixed for both of them, which is 1 milligram. Now, which one will have higher concentration? And remember, we were talking about the plasma. So when we talk about the concentration of the drug, we talk about the plasma concentration. We're not thinking about drugs that are bound to the protein. Okay, so yeah. So which one will have more concentration? This one. Because of that, the concentration will be higher, so the volume would be higher. So the volume will appear to be higher. Okay. I know why it's confusing, because you think it binds to the plasma protein, so it's contained in the blood, right? But we are really not counting those that bind to the plasma protein because they're not free. They cannot bind to the receptor. We're only looking at the ones that are in the serum, in the plasma itself.
So
and these have more amount, more concentrations. So if we give 1 milligram, it will appear that this drug is actually occupying smaller, this does not bind to the plasma, so it'll actually occupy smaller volume because it has higher concentration. This will appear to have as if it's occupying larger volume because some of the drug is binding to the plasma proteins here, okay? So it's like diluted into a larger volume when in fact it's just not, it's not there. It's just being busy somewhere else. John.
Okay. Although I'm thinking of this as far as this question as if this was a laboratory test that somehow only detected the drug if it was not bound, and for the purposes of the other implications of being free, that's convenient because you're wanting to know how much is unbound. Is this only fictitious for discussion? Like when you test it, do you have issues where you're sitting here going, well, I'm measuring the concentration, but I have to use this test so it doesn't detect? Or
No.
is it really that we are just going, if we
No.
were to test and have the ability to only test?
Right, so that's a good question. So his question is, well, this is an experiment, right? So what if I take the experiment and which concentration I'm looking at? The drug in both the plasma or the, in the protein and the plasma, or just the one in the plasma? Well, we only rely on the drug that is free in the plasma to do our calculations. That's it. All the experiments we do is we separate everything, blood cells, plasma, protein, and we only look at the serum. We only look at the concentration of the drug in the serum, and that's the one we base our calculations on. And that's why when you try to, get a drug into somebody's, blood, and then you want to make sure you have the right concentration, that's why you want to make sure you use the right volume of distribution. Okay, so one drug will have a different volume distribution, so we should use that volume when we do the math to see how much drug should I give that person. Okay.
I mean, I know that we're keeping pH the same
Yep.
probably anyway if it was a real test, but
Yeah.
so in reality, it works out that since we don't change the pH when you, I guess, centrifuge out the
So in reality,
proteins, you end up with correct.
Exactly. So in
situation as well. Okay.
So in reality, we actually separate protein, red blood cells, everything, and we only look at the serum concentration, because guess what? This is actually the true reflection of how much drug is available to bind to the receptor. Okay? Melody.
I'm trying to understand what you said here. So you said drugs that are bound to plasma protein have a lower volume distribution?
Okay, what do you think?
Well, I think you said lower. I think you said they only look at 3 drugs.
Volume of distribution is similar to if you filled the building with some flies and you went in that room and injected that room or let the flies loose in that room. After a amount of time, if the flies got out, you would hardly be able to calculate if the flies distributed evenly how big this building was if they went a certain equal number of flies to every square foot of this building or cubic foot. Well, if someone was sitting with a fly swatter or had a fly paper on the wall and they started sequestering the flies, where you would begin to believe that the building was bigger and bigger and bigger. So the protein that bind the drug mean that you get a lower concentration of the drug than you expected. So the volume can actually get, like if you killed all the flies, you would assume the building was infinite in size. I mean, is that, so basically calculating from one area how big the whole area is, as if everything is distributed evenly. It could be marbles or whatever. In a or guy in a pool, if you dump this much froth in the cup, you can calculate how much dye in one single pool or pouring in a pool. Then you can determine the area of the pool. But if you have some process in the area, pouring, maybe a bucket of muddy water or something, down the pouring, when you calculate how much pouring you have, and be like, oh, this pool is trying to determine
Okay.
what you put in, how big it is, how much bigger.
Okay. So let me.
So the proteins take some of it. So when you try to calculate the volume,
So another way to think of it is if you have plasma and you have plasma protein. So you have protein, you have let's say albumin. I mean, sorry, the serum. Okay. If the drug only binds to the albumin, then that's the only volume it's going to occupy. But if the drug is, I'm sorry, let me start over. So we have protein and we have plasma protein, we have the plasma serum. Okay. So if the drug does not bind to the plasma protein and only dissolve in the plasma serum, then that's the only volume it's going to occupy. If the drug binds, dissolves in the plasma serum and binds to the plasma protein, then guess what? It's actually occupying more volume. Okay, so think of the space or the places the drug is occupying. When it binds to the plasma protein, then it's actually occupying more space, more areas, more places, because it binds to the protein and also dissolves in the plasma serum. So it has more volume of distribution, okay? Just like we talked about the drug that are lipophilic, they cross the blood-brain barrier, so now they occupy more volume, the cerebrospinal fluid. Here, they bind to the plasma protein, so they occupy more areas, more volume, more places. Okay, so more binding to plasma protein mean they have larger volume distribution. Make sense? Yes, so drugs that bind to plasma protein have higher volume distribution, yes. Okay. And by the way, this was one of the questions I made bonus, okay? So this was one of the questions I noticed that many people missed, so I made it bonus. Okay, did you have a question, sir? No? Okay. Number 8. What statement regarding design of antagonist is most correct? So most of you got this actually accurate. So antagonists bind to extra binding regions that are not used. Antagonists bind to extra binding regions that are not used by the natural messenger. Yeah. And then antagonists are usually larger in size than natural messenger. We all know it's true because that's why they bind to extra binding regions, right? We add function groups to bind to these extra binding regions. And then antagonists have a stronger intermolecular bonds with the receptor compared to natural messenger. They do. Otherwise, they cannot compete with the natural messenger. We want them to bind to the receptor to compete and displace the natural messenger, right? Okay, so the answer would be D. Okay, number 9 is a prodrug. Okay, so we have a substrate, we have an inhibitor. It's going to inhibit this, but this needs to be activated. It's a prodrug. So we should, be careful whenever we say a prodrug. And notice that the effect is on the therapeutic effect. So when you inhibit the activation of this prodrug, then it's not going to be activated, so you're going to have less effects, right? So a reduction in the therapeutic effect of the cyclophosphamide, which is A. Okay. John?
on the previous question,
Uh-huh.
hopefully it didn't The third one was kind of like, yeah, that would be ideal, but sometimes the antagonist may be the same strength. I'm guessing sometimes since you don't really get to plan your drug, the only thing you come up with
Right.
is partial bind. So you would end up with a graph where
Right.
your antagonist, if it's the same strength, would be
Right.
identical strength. So that answer I knew was sometimes true.
Yeah.
And would ideally be true.
Mhm.
But at the same time, weight question was worded.
Yeah.
You knew
Mhm.
maybe definitely all the above.
Sure.
So
Thank you. Yeah. Yeah. Well, I mean, no, most of you guys got this right. Okay, so this is similar to what we explained earlier. We have drug X and drug Y, they bind to plasma protein. Okay. If we give both drugs at the same amount and knowing that they both have the same, we give them the same amount, okay? And then FYI, drug Y has higher binding affinity to the albumin than drug X. What is gonna happen? So hopefully you know that drug Y is gonna displace drug X, and then you're gonna have overdose of drug X, okay? Next one. Which of the following are non-competitive antagonists? So allosteric, we all know allosteric are non-competitive, right? Reversible antagonists. Reversible antagonists, are they competitive? They are competitive, right? Okay, so it is not correct. And then suicide substrates, they actually bind with a covalent bond, right? So they are not competitive. So the answer is A and C. 12, which is most correct. For a drug to be successful, it must have a balance between water versus fat soluble. We all agree it's correct. For a drug to be orally active, it must survive the first pass effect. That's correct. Drugs that are in the ionized form are less likely to cross the placenta, which is lipophilic, just like the blood-brain barrier. They're less likely to cross the placenta of a pregnant woman compared to drugs that are unionized. Well, not true, so it's all of the above. 13, and please stop me if you have any issues, okay? We have like 35 questions and I'm gonna try to go through them. But if you have issues, I will stop and explain. Which statement regarding managing drug interaction is most correct? So dose adjustment is preferred over choosing alternate drugs? No, we should never adjust a dose if we have another alternative, right? Because it's the safest way. And then drug-drug interaction with narrow therapeutic index is more likely to be serious. Yep. Monitoring the patient is not necessary if dose adjustment is needed. Of course, we should monitor the patient if there's a dose adjustment. And then drugs with serious side effects are of least important than, doesn't make sense. Okay. It's funny, right? Okay. Acidic drugs are absorbed through the stomach wall at higher rate when the stomach is empty compared to the stomach is full. So what is the pH when the stomach is full? What is the pH when it's empty? 1 to 3. And then acidic drugs, okay, and they cross the gut wall higher. So acidic drugs, if you remember the table, acidic drugs, do you want to have the pH less or high in order for the drug to be unionized? You need less pH. So it does actually cross the gut wall at higher rates when the stomach is empty. Okay, so it's true. Okay. 15. What is most correct about the toxicity of acetaminophen? Hepatotoxicity results mainly due to the limited supply of glucuronide in our body. It's limited supply of the glutathione, not the glucuronide, okay? And then the antidote, N-acetylcysteine, works through preventing the biosynthesis, of glutathione. It stimulates this biosynthesis. And acetaminophen has a wide margin of safety. No, it actually has a narrow therapeutic index, which is why we have issues with it if you overdose. I mean, not overdose. I mean, as soon as you take like 2 extra tablets, you pass the therapeutic window. And then consumption of alcohol induces oxidation metabolic reaction. Consumption of alcohol would induce this process here, the oxidation hydroxylase. We all know it's true. We all know this is how consumption of alcohol actually produce more of this NABQI, okay? Because it stimulates this enzyme. So instead of 5% of the drug going through this path, now if you have more of the enzyme, it's going to be, let's say, 10%. So now more of the NABQI that our body has to deal with. Okay. Explain the last one. Okay. B. So the antidote, N-acetylcysteine, works through preventing the synthesis of glutathione. Well, glutathione is the one, the limited supply of glutathione is the one responsible for the toxicity of acetaminophen. And the antidote, N-acetylcysteine, is actually given to enhance the production of more of the glutathione. So it actually stimulates the synthesis of the glutathione instead of inhibit or prevent, okay? Okay. So actually glutathione is a 3 amino acids, cysteine, and what are the other 2? Glycine. What's the third one? Anyway, so the cysteine is the one that is limited in our body. So if we give more of the N-acetylcysteine, it actually stimulates the synthesis of the glutathione, okay? A drug can either be a substrate for a metabolic enzyme, for example, the CYP2C9, or an inhibitor to a metabolic enzyme, but it cannot be both a substrate and inhibitor on the same metabolic enzyme. We all know it's false. We have seen an example of clarithromycin, which is a substrate for the enzyme and at the same time inhibitor, right? Which is why actually, which is how these inhibitors work. They are substrate for the enzyme. So when the enzyme is trying to metabolize them, they stick to the enzyme, they occupy the enzyme, they keep the enzyme busy, so then they inhibit the enzyme from metabolizing other drugs, okay? And this one here, blocking adrenergic receptor will result in reduction in blood pressure. So adrenergic means what? Sympathetic or parasympathetic? Sympathetic, which means fight and fight. So when you block that, then you get reduction in the blood pressure, for example, right? We all agree? Okay. So unless you stop me, I'll keep moving. So I assume that everything is clear unless you ask me. Okay, anti-muscarinic side effects associated with the use of muscarinic receptor antagonists is an example of what mechanism of toxicity? Okay, so we have an anti-muscarinic, okay, and drugs antagonist to the muscarinic receptor. They cause some side effects. Okay, so this is an example of what? Of binding to the intended receptor for the intended use. If that's the case, it won't be a side effect, right? So binding to the unintended, binding of drug to unintended, I'm missing receptor here. So, so binding to an unintended receptor at an unintended tissue. I just realized that this is a typo here. I know what you're thinking. So binding to unintended receptor at an unintended tissue. What do you think of B? So we have the intended tissue and unintended tissue. We have the intended receptor and the unintended receptor. So 2 by 2 is equal 4. You have 4 options, right? So it's either binding to the intended tissue with the intended receptor and non-intended tissue with the unintended receptor. No. See, it's not that confusing, really. If you say it 10 times, you get the credit for it. Okay, so antimuscarinic drugs, they hopefully should bind to certain receptors in certain tissues, right? But because they bind to other muscarinic receptors in different tissues, that's how you get the side effects, okay? So they hopefully, I mean, the right answer, if you can see it, because I don't, would be to the intended receptor at the unintended tissue. I have to check my answer too. Yeah, see, that's right. Well, Kendra. Yes, so actually, any of these could be a side effect except number 1, okay? Now, because we are talking about the muscarinic receptor and the anti-muscarinic side effect, so we know it's the muscarinic receptor, okay? Yes, Melody.
Then couldn't it also be B if it found like allosterically or something from a receptor you didn't intend to bind to?
Well, so it's unintended receptor. B says unintended receptor, and here we're talking about the anti-muscarinic, so it actually produces the effect because of the muscarinic. Okay, so is it still a muscarinic receptor or a different receptor? Okay, so forget about the, I guess the, okay, so I guess the key point I want you guys to get is that if the drug binds to the receptor, if we design a drug to bind to receptor X, okay, and we want the drug to bind to receptor X in the lungs, for example, okay, but if the drug goes and binds to the same receptor X, but it's located in the heart, then that would be a mechanism of side effect. Okay. Another mechanism is we design a drug to bind to receptor X, but now it binds to receptor Y, regardless, in the heart, in the lung, wherever that is, it just binds to a totally different receptor. So that's another example of side effects. Okay. Well, I mean, forget about this question, okay? Consider it bonus, but think about the idea itself, okay? So receptors are located in different parts of our body. Ideally, you want to target the receptor in one part. For example, you want to target the beta 2 receptors, okay, to expand the lung bronchioles in the case of asthma, okay? So you want to bind to that receptor in the lung. Now, if the drug binds to beta 2, but guess what? Not in the lung, but in the heart or in somewhere else. So then that's an example of side effect. So that's one scenario. Another scenario is the drug binds to alpha receptor, not beta, but it's located again in the lung. So you get the right tissue, you get the drug to come to the right tissue, but then it's binding to a different receptor. So that's another scenario. A third scenario is the drug is binding to alpha and it's not even in the lung, it's in the heart or somewhere in the veins or somewhere else. Okay, so 3 different scenarios for drug toxicity. The only preferred scenario is, the only one that would not give you a side effect is if a drug binds to the receptor in the intended tissue. Okay, so we have the right tissue or the wrong tissue, we have the right receptor or the wrong receptor. 2 by 2 is 4. So 4 different scenarios, only one of them will give you the effect, the other 3 will give you side effects. Okay, I know this part is confusing, but it's not clear which receptor is it binding to, so it's okay. Don't worry about the question itself, worry about the concept itself, okay? Make sense now? Say it again. I know, yeah, I see why it's confusing now. When I sometimes write the question, I think it's just common sense, but then when we discuss it, we realize, no, there's all these possibilities, and then, but think of right, wrong receptor, right, wrong tissue. There's 4 different scenarios. 3 of them would be wrong, 1 of them would be right. The right one is the drug binds to the correct receptor in the correct tissue, and then anything other than that is wrong. Okay? Anything else could be cause and side effects. Okay? Now, if the drug binds to the same receptor, to the right receptor in the right tissue, but if you have more of the drug, then now you have side effects. Okay? But that's another story. That's an overdose. So that's another mechanism of drug toxicity. Okay, any issues with this, guys? I was hoping not to add more bonus questions. How dare you? Okay, 19. Okay, so enalaprilat is a prodrug. Is the active form. Enalapril is the prodrug. And then sentence A says enalaprilat can be taken by IV administration. So one of the comments from you guys was, it was not in the notes. How do we know that it's taken by IV? So this is actually more like, I guess, a conceptual question. It's about, if a prodrug is designed to overcome the challenge of absorption from the stomach. Well, if you take the drug by IV, then do you still need to use a prodrug? No. Okay. So this is one of the questions I gave bonus, but again, I care about the concept itself. When you work at the pharmacy in retail, you will see names that are different from the names you see at the hospital. For example, in retail pharmacy, you will see enalapril. You go to the hospital, you will see enalaprilat for IV infusion. Why? Because in the hospital, they use IV, right? IV drugs more common. So you don't have to worry about the absorption. They don't have to worry about the first pass effect. So you will see different drugs, okay? Right. And then option B, enalapril cannot cross the gut wall. Well, it's a prodrug and it's designed to cross the gut wall. So it should. So this is wrong. Okay. And then enalaprilat is a prodrug, which is wrong. Enalapril is a prodrug. So this is wrong, right? Wrong. So the answer would be A. But it was given as bonus anyway. Okay. Yes, ma'am. Right. So the enalapril is the prodrug. Enalaprilat is the active form. True. Okay. Sure. Okay. Number 20. Yes, ma'am. How do we know? Okay, I think, well, I assumed because we had an exercise on it and we explained how the ester is being added to the drug to improve its ability to cross the blood, the gut walls. I assume that you guys already got that. So yes. See, if I have not given you like an exercise, I would tell you this is a prodrug. Like in one of the other example, the cyclophosphamide, I told you it's a prodrug. Here, because we had an exercise and we practiced, and so I assume you know that enalaprilat is the active form, enalapril is the prodrug. Okay, next one. So we all know this is false. This drug is not active, but why is that based on the SAR? Right? We should have only 2 carbons, not 3. 1, 2, 3. So by having 3, it's inactive. Okay? So this is like, I think I'd like to think of this question as a giveaway because you just have to read and apply, Okay. 21. Okay, acetylcholine binds to nicotinic and muscarinic receptors using 2 different conformations. We all know this is correct, right? Remember, there's the gauche and the anti-conformation. One of them is preferred by the nicotinic, the other one is preferred by the muscarinic. Acetylcholine can be administered orally. No, why? It's not stable to the stomach acid, correct? Okay. And then acetylcholine binds to adrenergic receptors. It does not. It binds to the cholinergic receptors, right? And then acetylcholine shows selectivity between different types of cholinergic receptors. I wish they do. They actually bind to all cholinergic receptors, muscarinic and all that. I just realized it's 12 o'clock now already. So we already know that this is the only one. You guys need a break? Okay, let's take, well, maybe some of you want to grab lunch or something. So let's take like 5-10 minutes break. If you want to grab lunch, if you want to, use the bathroom or something, stretch and come back, and then we'll continue, okay? So let's come back at 12:10. Okay, I'm sorry. Okay, which question did we get to? I think number 22, right? Okay, so 22. This is okay. So this is similar to the one we had in the rat. So this drug binds as a muscarinic receptor antagonist. Okay, that's already here in the part of the question. And then propethylene binds to extra binding regions that are not used by acetylcholine. So acetylcholine binds here, propethylene binds to extra binding regions. So that's correct. And then the binding of propethylene causes an induced fate different than that of acetylcholine. Of course, that's what antagonist does anyway. And then propethylene can also antagonize the nicotinic receptors. Can they? No, they only bind to the, well, they only antagonize the muscarinic because actually the nicotinic receptors, if you remember, would only require two positively charged nitrogens or two positively charged within certain distance to block the nicotinic receptors. Okay. Okay, so answer is A and B. Next. The distribution of different types of adrenergic receptor in different parts of the body is good for designing selective drugs. Right? When you have different receptors distributed in different tissues, that's a good thing. Why? Why is it good to have different receptors distributed at different parts of the body? Let's look at the other scenario. What if you have the same receptor present in different parts of the body, and then you want to target this receptor? Guess what? Are you able to select which tissue you want to target? No, because you're going to have the drug binding to all these receptors in different tissues. But then when you have, on the other hand, if you have a beta 1 in the heart, beta 2 in the lung, alpha 1 in the vessels, and so forth, then when you design a drug for beta 1, then you can be certain that it's going to only bind to beta 1 in the heart because there is no beta 1 in the lungs. Okay. Okay. Which of the following statement is most correct? Drug X has larger therapeutic window than drug Y. Do you see the window? Okay, so yeah, this is correct. Drug Y has a peak effect. This is a peak effect, right? So that's correct. And then A and B is the correct answer, of course. That's number 25. Anticholineesterases are used as smart drugs in treating people with Alzheimer. Well, that's correct, right? They inhibit the acetylcholinesterase, the cholinesterase enzyme, so you have more of the acetylcholine. Okay. What statement regarding autoreceptor is most correct? So they are located at the presynaptic. Okay. Binding of acetylcholine to the autoreceptor inhibits the release of acetylcholine. Always, anytime you bind to the autoreceptor, you give a negative feedback. You prevent the release of that neurotransmitter. Autoreceptors regulate the release of acetylcholine, of course, and then all of the above. Okay. 27. Example on the uses of prodrugs are improve the absorption of drug. We have seen that, like in the enalapril. And then optimize the duration of action of a drug. Sometimes we design a drug by making it more lipophilic, so it stays longer in the body, and then increase duration of action. And then enhance the taste of a drug. We have not seen examples of that, which is probably the reason why you guys got confused and I used this question as bonus. But you will see that later on that some drugs have horrible taste, okay? So even though you take it in the mouth for, you take it in your mouth for a few seconds, they still touch your tongue and they give you this horrible taste. So how can we fix that? By making the drug more lipophilic. When it's lipophilic, it's not going to be able to dissolve in your mouth. We will see examples of that, like chloramphenicol, for example. So it's lipophilic; it does not dissolve in the mouth. It's not going to touch the taste buds, and then when you take the drug, you're not going to feel the taste. This is one technique. We will see examples of that when the antibiotics. But that's not the only one. You could also sugarcoat it. Okay. So yes, ma'am. Yeah, so it's actually, this is select all that apply, which is another reason why you guys got confused. Many of you, or some of you were selecting only one answer, okay? So it's, this is correct, this is correct, this is correct. And improve the chemical stability of a drug, yes. Many times we use prodrug to enhance the chemical stability. Yes, Kendra. Say it again, Okay. Yeah, no, that's true. Yeah. In the notes, yeah, I know. Yes. Yeah, I know. I mean, I know it's in the notes, but because it's select all that apply, many of you just assumed it's multiple choice question and picked one answer. So, okay. 28. Right, this should be an easy one. Geometric. Anytime you have double bonds is geometric. And then this is a mirror image of this. So it's optical. And then we have rotation around a single bond is conformational, okay? So that would be BAC. No, I'm sorry. CAB, yep. Yep. I should never rely on my memory. I was thinking BAC. Okay. Yes, ma'am. Okay, sure. So anytime you have rotation around that double bond, it's a geometric isomer. If it's rotation around a single bond, it's conformational. And then the last one is mirror image of the other one. It's optical. Okay. Imagine having a mirror here. Okay. And then synergies, these are definitions. So we know that in the case of addition, it's 1 + 1 = 2, right? So two drugs, you put them together, the effect is equal to the summation of both together. So that's an addition. So equal to the addition of 1, so that would be C. And then two drugs have same effect together, but when you put them, two drugs are active, when you put them together, the effect is more than the simple summation of both. So now we have 1 + 1 = 3 or 4 or 5. So that's synergism. And then a drug that has no activity whatsoever, but it affects the activity of another drug by increasing it. So that's potentiation. Okay. All right. Next one. drugs that are highly bound to plasma protein compete among each other. Which phase does this happen? Does it occur in the absorption or the distribution or the metabolism or excretion? Which phase do drugs interact for the plasma protein distribution? Okay, so this is B. Okay, two drugs taken orally, they form chelation complex and they do not get absorbed. They do not cross the GIT. So that's at the phase of the absorption, which is A. And then grapefruit juice inhibits an enzyme where this is metabolism phase, right? C. And then positive allosteric modulators, that's a pharmacodynamic. We're talking about at the level of the receptor. So we have E, pharmacodynamic. And then acidifying the urine, that's the elimination phase, right? Or excretion, D. Okay, here we have an experiment and we have three different results or three different drugs. One of them is active, one of them is also active, another one is not active. If you compare between them, you will see that we have two different groups. Since the drug remained active in these cases, this tells us that these groups are isosteres or bioisosteres, and they are important, of course. So they are part of the pharmacophore. So this is option one. The benzene ring is one of the pharmacophoric groups. The same applies to the pyridine. But then, are they both bioisosteres? Yes, because again, a bioisostere means you substitute a group for another, and the drug remains active. And since they are bioisosteres, they're also isosteres because exactly. So bioisosteres is a subclass of the isosteres. So if this is, the isosteres, then part of that is bioisosteres. Okay, so we already know that this is correct. Okay, so all of that above. Next one. Okay, so we have two drugs and we are provided with the function groups and the table. We're gonna do the empirical method to measure the solubility for these drugs, okay? Did you guys do the math for both of them? Okay, how much did you get? How many carbons do we have here? Let's say number of carbons here, let's say the number of solubilizing potential, SP. And here the SP, number of carbons. So this is an easy, amine and alcohol, alcohol and amine. So 3, let's say at the most 7. So 6 to 7. How many carbons do we have? 1, 2, 3, 6, and 3 is 9, 10, okay? Is it soluble or insoluble? Insoluble because 10 is higher than 6 to 7, okay? This one here, we have ether, phenol, amine, amine. So 2 amines, 6, ether, 2, that's 8, and 3 to 4, so that's 11 to 12. How many carbons? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 14, 15, 16, 17, 18, 19, 20, 21, 22. So it's also insoluble because 22 is bigger than 11 to 12. So we know A is correct, B is correct. Now the tricky part is which one is expected to have higher log P value? What do you think? So guys, if you look at the difference here, what's the difference between the number of carbons and the number of solubilizing potential? It's about 11, right? What's the difference here? 3 or 4? Okay. So this is 10 to 11. So here you have more carbons to solubilize than here. So this X would be expected to have more lipophilicity, and so I would expect it to have higher log B value. Make sense? Which is the reason why I made this question bonus, because I felt it's, you know, tricky, or many of you missed it. Say it again. Sure. Okay, so the whole idea of the empirical approach is you compare how many carbons am I able to solubilize, how many carbons are remaining. So for one of them, you're left with 10 to 11 carbons that you did not solubilize. For the other one, you are left with only 3 to 4 carbons. So because of that, even though both are insoluble, but because one of them has more carbons to solubilize, it's more lipophilic. More lipophilic means it has higher log P value. Make sense? What do you think? Yes. Correct. So anytime you have higher lipophilicity, it means it's more log B is higher, okay? More lipophilic, higher log B. Okay. Oh, 3 more, and then we'll be finished. Okay. Which statement about the binding of chemical messenger to its receptor is most correct? Chemical messenger undergoes a chemical reaction before it departs the binding site. We all know it's incorrect. The binding should usually be weak enough to allow the messenger to depart, and also strong enough to allow the signal transduction. We all know this is correct. When agonists bind to the receptor, they cause the same induced fit as the natural chemical messenger. They should, right? Agonists, they should produce the same induced fit as the natural chemical messenger. And then the binding site for the chemical messenger is located deep inside the receptor. No, it's at the surface. So it's B and C, okay? This one. What would be the results of combining an agonist with a competitive reversible antagonist? Both have the same binding affinity, and they were given at the same amount, the same concentration. Yeah, partial. So they both have the same binding affinity, so they will compete for the receptor. So 50% of the time, you will see the agonist effect. Another 50%, you will get the antagonist. So overall, you have some effect which is in between the agonist, the full agonist, and the zero antagonist. So it's like having a partial agonist, okay? Questions on this one? Kendra? So remember, so imagine you have an agonist, a full agonist, and an antagonist, and they both have the same binding affinity, so they compete equally, and they both have the same concentration, so again, they compete equally, right? So how is the receptor gonna respond? What therapeutic effect will you see? Are you gonna see the effect of the agonist or the antagonist? Which one are you gonna see? Why? If they have the same binding affinity and they are present in the same amount, don't you think that they will equally compete to the receptor? So at one time you'll see the agonist binding, at the other time you'll see antagonist, and they will share the time. So 50% of the time this will bind, 50% this will bind. So overall, the effect would be similar to a partial effect, because you're not getting the full, you're not getting the zero. Okay. Say it again. Yeah, so partial agonist, or remember, partial agonist is another name for partial antagonist. So guys, remember, never forget, partial agonist is the same as partial antagonist. Okay? Last question. What statement about natural products most correct? Standardization of herbs is easier compared to prescription? No, it's actually, that's a problem with the natural products, that we cannot be sure how much how much in this bottle using herbal drugs. Different manufacturing companies will have different amounts, different type of herbs will have different, chemical instituents. Okay, the chief class of drugs that causes major drug interaction of herbs are immunosuppressant. Which one? Blood thinners, right? A typical, and the reason I keep asking this question, because you will see many times people coming to you and tell you, oh, I'm taking this herbal drug. Can you check if I can take it with my medication? So the major concern is if they take blood thinner, okay? Because some of these herbs can cause blood thinning. Now, this is just, like a simple answer. You should not, just only rely on this, but this should bring a flag. If they have blood thinner, if they are on a blood thinner medication, they take an herbal medication, then there is a chance that they might have, hemorrhage, bleeding. So, but, you should always, of course, check everything possible, with all their drugs, but this one is like the most common, okay? And then a typical herb contains a single constituent. I wish they do. No, they don't. They have many multiple constituents, which is the reason why we get all these effects. And then prescription drugs are purer substances compared to natural products. Of course they are, okay? Otherwise we wouldn't have pharmacists here. Okay, so this concludes our exam. Any questions? Okay. Well, I cannot believe that next Monday we have another cat. Can you believe it? I know. This is so quick. I didn't even finish grading this. I still have to grade the T-cat, the team component. That's the fun part, right? It's like looking at all these cards and anyway, so be prepared, okay? So the material will be covered until Thursday. So the cat on Monday will cover everything up until Thursday, which is Dr. Pearson's lecture. Wednesday, we will talk about, some other topics, the depressants and stimulants, CNS depressant and stimulants. And that would be, as far as my component, that would be the last part that will be covered, included in cat number 2. Okay, before we break, any questions, guys? Any questions? Okay, well, I'll see you later then. Have a good day. Thank you.